group of clinicians who are involved in the care of transplant patients, and we thought it very important to get information into the hands of patients and their families. We've been doling it out one by one as we see patients, but this forum is essentially to try to bring you up to speed on where things stand and give you an opportunity to ask questions. I will introduce the speakers, and if folks are joining late, that's fine. We are recording this webinar, and it will be posted on YouTube, and we'll figure out a way to send a link to the people who registered online for it. So just to introduce our speakers, we have Greg Lewis, the medical director of the transplant program, in addition to many other roles that he plays. Lana Tsao, associate director of the transplant program. Megan Doucette, lead transplant nurse practitioner. Myself, I'm a heart failure cardiologist, transplant cardiologist, and Camille Cotton, who is a transplant infectious disease specialist. She also has her ear to the ground because Camille is on the ACIP external review panel that advises the CDC on its decision-making about immunization for a variety of conditions, including COVID, and they've had many emergency meetings. We will have live captioning for this, and we will also be posting the YouTube, which will include the captioning. So off camera, we have assistance from Stacy and Kathleen, who've been helping us out. We'll get this organized, and Stacy's asked me to pause for a moment. So I will wait until Stacy has given the go-ahead. Camille, can you confirm that you have slide presentation capability?
That's a good point. Yes, I do.
I'll let you know if I see it. If you want to share your slides, you can.
We good?
Perfect. And Stacy, do you want to let us know? We have a chat that we are able to use to communicate among the panelists. The people who are tuning in, it looks like there are 18 participants. We will be keeping the identity of the participants screened just for patient privacy reasons. We won't be answering specific questions about specific patient issues, and we also won't be able to answer very detailed and specific questions. Sometimes we'll just have to punt on those and ask for folks to follow up with us in the transplant program. And it looks like we should be ready to start. So Camille, do you want to share your slides and get started? Stacy gave us the go-ahead as well.
Sure, will do. Let's see. All right. So nice to see everybody here tonight. The goal of this is really to give you as much knowledge and information as possible. And there's some really cutting edge information. I was actually just making slides when Dr. Newton-Jay was opening this up. So there's some new data that just came out. So we wanted to make sure that everybody really has as much information as possible. So just by way of background, so what are the most recent trends? Many of you would have seen this in the news, but we've had multiple waves of COVID. And unfortunately, it looks like we had been recently trending down, but now, as you can see on the far right, we're actually perhaps on the way up nationally, which is disappointing. What about in Massachusetts? Similar data where we'd actually been trending down, and then over the past week, we've actually doubled our numbers of positive test results. So that's really disappointing. We had hoped that it would be otherwise.
Camille, if I could just interject one thing, which is a reminder to the participants, if you have questions that you would like addressed after Camille's talk, which will be about 20 minutes, feel free to post them to the Q&A. You won't see those questions until we've answered them, but I and the panelists will, and I'll be queuing up the Q&A for after Camille's part. Thanks, Camille.
Great, thanks a lot, Chris. And so, right, so here's the Massachusetts information. And then, sorry, so what about hospital admissions? And you can see that overall, you know, it was pretty bad in early last winter, a year ago, and then we'd been trending downwards. But unfortunately now, especially in people over the age of 70, we are seeing sort of a rise in hospitalization rates, which is unfortunate. And then something that's really, really interesting that many of you have probably heard of, but we actually track the amount of virus in wastewater. And this is Massachusetts data. And basically in orange, it's from the southern part of eastern Massachusetts. And then in green, it's from the northern part of eastern Massachusetts. And you can see that overall, our numbers had really gone down. You know, last June was when Dr. Rochelle Walensky at the CDC said that we could relax, take off our masks, et cetera. And this is really why, because we had very, very low rates of virus. And then you can see in the late summer, and then more recently, we've really picked up the amount of virus in the wastewater, which suggests a high rate of virus in the community. This is sort of a very interesting way to look for data, certainly. What about breakthrough cases after vaccination? So we know that there are a good number of breakthrough cases, but I was really pleased to see this data for the state of Massachusetts. And as of the end of October, of over 4.7 million people who are vaccinated, approximately 1.1% have had a breakthrough case of infection. But what's really impressive is we are having a good number of breakthrough cases. You know, we're up to over 55,000. But vaccinations really prevent hospitalizations and death. So overall, across the entire community, those numbers look really good. And then this is the, let me make sure, yes, this is the slide that I just updated. So this is who's been getting COVID by vaccination status. And you can see that people who are unvaccinated really account for the majority of cases by far and large. And they have people who are unvaccinated as of September have almost a 6 times greater chance of testing positive for COVID compared to people who are vaccinated. And they have a 14 times greater risk of dying from COVID. So vaccines are really, really working. This slight trend upwards in sort of August, September, and October was what actually led us to recommend booster doses, and I'll talk more about that, but that drift upwards is the reason for that. Now, as of August, we told all transplant patients that they should get an additional dose of vaccine, and it's pretty confusing to talk about additional doses versus booster doses. So an additional dose of vaccine is when, instead of it being a 2-dose series, we actually decide that it needs to be a 3-dose series. So for many hepatitis B vaccine series, it's a total of 3 doses. For shingles vaccine, it's 2 doses. So an additional dose just means that for the primary initial series, you need an extra dose. Whereas a booster dose is when you get a strong immune response up front, but then the immune response drifts down over time. Like some of us need a tetanus booster every 10 years, but we had an initial strong response and then our immune response drifts down. So that's really what that distinction is, because it's confusing to hear additional doses, 3rd dose, booster dose, and what's all the difference between those things. So I know that many of you heard about this in August, that for moderately to severely immunocompromised patients, we on the CDC panel recommended that everyone get a 3rd dose of mRNA vaccine. And I want you to know that I personally worked very hard for this recommendation and did a lot of work over July and August, and was really happy when we were able to make this recommendation. And so hopefully, most of you have had the additional dose of vaccine, and if you haven't, we would generally encourage you to do so. There's data that came out today, and this is from the group in Toronto at the Transplant Center there, led by Dr. Dipali Kumar, who's a close friend and colleague. And they basically did a randomized trial where they looked at 117 patients who'd undergone organ transplant, of whom 60 got a third dose of Moderna vaccine, and 57 got nothing, no vaccine. And what they really saw was a significant increase. This is for different virus types across the bottom, like wild type, alpha, beta, and then the famous Delta that I'm sure you've all heard about. So let's just look at Delta. So those that did not get a third dose of vaccine had this lower dose of antibody titers compared to people as seen here with this gray cluster on the far right. They had a much more robust response after that third dose of mRNA vaccine, Moderna vaccine. And that was across the board for all different virus strains. But this really shows that that third dose really does help increase the amount of antibody, what they specifically call neutralizing antibody. But basically that third dose does work. And this was a beautifully done trial that was published in the New England Journal of Medicine. So nice work. Now let's switch to sort of away from that third dose for transplant patients. And last week we made a recommendation that across the United States, people over the age of 50 who previously had mRNA vaccine, 2 doses and are now more than 6 months out, should get a booster dose. And that's for people with no significant risk factors, people in long-term care facilities, or people who had 1 dose of J&J vaccine. And so people who are under the age of 50 and have no major risk factors for severe COVID may get a booster. And I think many of you heard about this. This was in response to the governors and other people really clamoring for for booster doses. This is more for the general population, not for transplant patients, but this probably applies to many of your family members. So we would hope that if your family members are more than 6 months out from their vaccine, or more than 2 months out from J&J, that they would be getting these booster doses. This is another way to look at the recommendations that we made. And so here's in red, if you had Pfizer or Moderna, we recommended that additional dose at least 28 days after the primary series. And then we do recommend now booster doses. And I want to be really clear that for transplant patients, we recommend booster doses at least 6 months after that third dose. So we actually are up to 4 doses for transplant patients with that booster dose for people who had mRNA at least 6 months after the third dose. I do want to emphasize that Moderna is half dose because it's much more likely to cause a reaction, fevers, feeling poorly, etc. So we cut the dose in half and it still results in a strong immune response. But just to be clear, because it's confusing. So immunocompromised should get a booster 6 months after the third dose of mRNA vaccine. We can talk more about that. Now, there are a ton of questions out there about should you get, if you had COVID, you or your family member, or loved one, or community member had true COVID, should you get vaccinated? And the answer is absolutely, absolutely. So people who had prior infection and didn't get vaccinated were 5 times more likely to get infected in the future. So that is clear. Natural disease does not protect you as well as vaccine. So if you have family members who aren't yet vaccinated and say that they are protected by having had prior infection, that's not what the science shows. And I would encourage you to ask them to go get vaccinated to help protect themselves and protect you, perhaps as a holiday gift to you. So why don't we check antibodies after vaccination? And we get a huge amount of questions about this. So this is not recommended by the CDC, and thus at this point, we're not recommending antibody testing. Vaccine protection is a combination, and this is really important. It's both antibodies and this other type of immune response called a cellular immune response. So it's those two together. And right now, we don't know what level of antibodies actually provide protection. So we would hate to do testing and say like, oh, you have, this many antibodies, but we don't know what it means. And we would not want people to sort of maybe go and do risky things thinking they were protected when they're not actually well protected. And we don't recommend that you get antibody testing or based decisions for vaccines on antibody test results.
Camille, do you mind if I jump in with
right
some of the
ahead.
questions that
Sure.
we got when people were registering for this that are related to this? So the questions were, can we get antibody testing done? It sounds like you just said there's not a should for getting it done, but that people can. It sounds like some people have. But we don't know what to do with the information.
We don't recommend it. We don't recommend it. And it's actually not allowed at Mass General Brigham across the whole enterprise because it's not recommended by the CDC. We can't actually order it. There's some people feel like we're not being nice or we're, not doing what they want us to do. We actually can't do it. It's a hospital policy violation if we do it.
Yeah, I would say I've seen that even primary care providers at our institution, if they have access to outside labs, have been ordering antibody tests in some patients. So it's definitely a relevant question, but it's good to hear from you that you don't think our patients should make decisions based on that. And then there were some questions about high antibody levels in some quantitative tests and whether there's more information there. And it sounds like we just don't know. All right, that was it for the questions so far that are related to that.
Okay, all right, whoops. Sorry, I took my slides down.
And I guess there's a related question. If you could go back to your prior slide, maybe before that, sorry. On this one, nope, this one, yeah, that's perfect. Can we talk a little bit? So one question was, I got 2 doses of Pfizer and a booster 6 months later. Am I gonna still need an additional vaccine? I think I heard you loud and clear. You said yes, 6 months after their 3rd vaccine, transplant patients will need another one that we would call a booster rather than an additional dose.
Yep, exactly. That's exactly right. And you can mix and match. Like if you got Pfizer, and honestly, there's not data to suggest like picking one over another. So if you got 3 Pfizers, your next one could be a Moderna, knowing that the Moderna would be the 50 microgram, not the 100 microgram. Or you could, you can pick all the same, you can mix and match. I tried to mix and match, but I couldn't find a Pfizer readily available. So I went with a Moderna, having had Moderna. You can do whatever, any of those are fine. Honestly, Chris, I do want to say that I'm just kind of staying away from the J&J because we have seen more potential complications with it. And I just tend to think that the mRNA vaccines result in better protection and just incredible safety is what we've seen.
Got it. So some of the, one of the questions that we got related to this is, are we recommending a specific vaccine? And I'm gonna take Camille off the hot seat and maybe ask Dr. Lewis or Dr. Tsao, because I appreciate the CDC and the FDA have given a lot of latitude to clinical providers to help their patients make those decisions. Can I just ask Dr. Lewis and Dr. Tsao, this is obviously not official regulatory policy, but how are you advising patients who, let's say they've had 1 dose of J&J or they've had 2 doses of Pfizer or 2 doses of Moderna as regards to the boosting decision?
Sure, Lana, do you want to start and then I'll talk to you?
Sure. So the data for the Moderna vaccine has looked stronger to me, although I'm not supposed to be in favor of a specific vaccine. And the CDC also doesn't recommend a specific vaccine, but the antibody response has been greater. So I've been advising my patients to get the Moderna vaccine. And if they've had the J&J, I've been advising them to get the Moderna for the booster.
What if they can't get Moderna? Like what if the they're scheduling too far out? Do you think it's better to wait like 3 or 4 weeks and before getting that Moderna, or what do you think about just going with Pfizer if that's what's available at the pharmacy?
If that's what's available at the pharmacy, then I tell them to get that. I've actually had that situation.
How about Dr. Lewis?
Yeah, thanks, Chris. And our attendees are masked here for the purpose of privacy, but we can see the attendees that are logged on. So it's great to see all of your names here, and thanks for joining. I just want to make one comment before I comment on the vaccines. The slides that Dr. Cotton just showed you, you may have noticed some of them were updated as of November 23rd. And that's how lucky we are around here, because we have world-renowned infectious disease specialists that are literally up to the day in terms of the data review and the latest knowledge and the kind of cutting edge here. And Dr. Newton-Shea from our group has also taken a very vested interest in COVID-19 and its effects on our patients. So we really are committed as a team to trying to do everything we can to help keep you protected as our patients who've undergone transplant. And one other quick editorial, which is, you've done a great job in keeping yourselves protected for the most part too. The rate of COVID in our transplant patients post-transplant is lower than the rate in the US population, which is terrific. And we do have patients that have gotten COVID and have certainly gotten through it. In terms of the vaccines, I think one of the reasons that we've been doing as well as we have been is because the vaccine rates are really high in our patients. And that table that Dr. Cotton just showed you, I think is the absolute key. If you go by the booster recommendations, I think this 4th dose is probably new news to many of you that are on the call right now in terms of the recommendation. But it's so important to follow these. You've seen that the vaccines work. These mRNA vaccines are really pretty incredible in terms of how quickly they were developed and how safe they are and how effective they are. So I don't want you to feel like you're kind of in trouble if you've gotten the Pfizer vaccine or even if you've gotten the J&J vaccine. But if you follow this protocol of getting the boosters at this time interval, the 28 days after your first one, the additional 3rd dose, which many of you have had within our program kind of to a T, and then this 4th dose, which is the half dose of Moderna or the full dose of the Pfizer, then you're doing all the right things, basically.
Great, thanks very much. Maybe back to you, Camille, to keep going through the slides. And if there are questions that come up germane to other slides, I'll interject.
Great. Thanks a lot. Those are all really great points.
There was, sorry, one last question that just came in. So can you explain the half dose of Moderna? The participant asked, would we have to ask for a half dose from the provider when you're getting your booster, or if you're getting your 3rd dose? How does that work?
So for the 3rd dose, so it's confusing, right? So for the 3rd dose, which is here in red, that's actually full dose. So that 3rd dose is full dose because it's an additional primary dose. So it's only the booster. So when you're getting Moderna as a booster, and this is confusing to everybody. So only when you're getting Moderna as a booster, so that would be like your 4th dose, 6 months after your 3rd dose, that's when it's the 50 micrograms. And if you're registering at CVS or Walgreens or whatever, they actually guide you through this. And to be honest, no harm done if you end up getting, one instead of the other. I mean, we would prefer, if you have to err on one side, it would be better to get the 100 microgram full dose. And if you got that as your 4th dose, I mean, technically, no, we don't think any harm would be done. It's sort of not what's recommended, but we don't think any harm would be done. It's just that you're more likely to have a strong reaction and have fevers and feel lousy and that kind of thing, but there's no harm. So it is confusing, but if you go through and answer the questions correctly when you're registering for the vaccine, it should be okay.
Great. And can I ask, so a corollary to that, let's say someone gets, let's just pretend they get 2 Pfizer doses, and then in August or September, they got their 3rd dose once the immunosuppression indication came in.
Yeah.
If they got 100, they're done. That was the complete series. If they got, let's say, Pfizer, and then a half dose Moderna as their third, do you recommend that they top it off with another half dose Moderna, the 50 micrograms, to bring it up to 100 for that additional third dose?
That's a great question. And I do recommend that they would try to get an additional 50 micrograms to make it a full 100 micrograms as their third or additional primary dose.
Great. So, Sorry.
It might be tricky to do. So you might have to like register at 2 different pharmacies or something like that. I don't know that like CVS would let you go twice. And the computer might actually block you. I guess if it's a problem, you could let someone know and maybe we can help. Although we don't have such great vaccine availability at Mass General, but we could sure try to help.
Certainly, you can assume that it's possible the person administering the vaccine to you will be unfamiliar with these recommendations. They'll be giving you what they're set up to be giving. They won't necessarily be in a position to give you advice about, 50 milligrams or 50 micrograms or 100 micrograms.
Yeah, really good point. Really good point.
Great,
so
back to you.
I put vaccine availability into the chat, so hopefully people can get these numbers out of the chat. If you have trouble finding, access to a vaccine, I'm sure your primary care doctor could help, doctor's office could help you. There are many that could help, but they're amazing. Like you can send your zip code to this text number and like they guide you through it. There's lots of cool things going on there. And then in early November, we did make a recommendation for children aged 5 to 11 to undergo vaccination with the Pfizer vaccine. And this is over 90% effective. It's really safe. We're not recommending any boosters for this population. Right now, I think it's over 8% of children in the 5 to 11-year-old age group have been vaccinated. And, one thing that came up on the call was, so this is a CDC call. It actually had the most people watching this call ever. It's kind of like watching C-SPAN or any other government meeting, but we had 50,000 people watching this meeting. And at the end, we all talked about how we are vaccinating our children, our grandchildren, and this is something that we really believe in. And we really believe in the safety and effectiveness. And I will also say that in the infectious disease division at Mass General, all my colleagues sprinted out to get their kids vaccinated in this 5 to 11 year age group. So really good uptake, and we would really encourage this, in part because this is pediatric hospitalization data, and you can see that they kind of follow the adult numbers. I just talked to a colleague who is in Cincinnati, who is one of the best transplant infectious disease specialists for pediatrics in the country. And she says she is seeing a devastating number of sick children. And this COVID-19 has caused more pediatric death than any other vaccine preventable illness. And it's 3 times more in the past year than any other vaccine preventable illness. So there's
can you give some examples of vaccine preventable illnesses that kids routinely get?
Measles would probably be the biggest one. Chicken pox as well. Those would be the most common ones.
And those are routine. Most kids get those because of the schools.
Everybody, right, absolutely. And if anything, to be really honest, this vaccine is safer and better tolerated than any of those other pediatric vaccines. Like measles is a live viral vaccine, and I totally believe in pediatric vaccination and vaccinated my children as recommended. But this is even safer than those vaccines. So I personally don't have any concerns, and I would easily vaccinate if I had a 5-year-old. I have teenagers now, but yeah. I've
had some patients comment on their kids not having comorbidities, and they're having heard that COVID illness is mild in kids and they're unlikely to get sick. It sounds like you're saying many kids have gotten very sick and have died. But can you comment on the comorbidity thing? From a perspective of kids, do the kids benefit only if they have comorbidities, or how does that work out?
Yeah, so perfect timing, right on this slide, which is another one that's hot off the press. So many people are saying, oh, those were kids who were sickly or whatever, or they had problems such that they were going to have major complications. But if we looked at the number of kids who were hospitalized, almost half of them had no known medical condition. Well over 30% had obesity as well as a risk factor. So unfortunately, childhood obesity is quite common. And then asthma, not quite 20%. But you can see that the majority of the kids had either, asthma, obesity, or no known medical conditions. So it's not really right when people are saying, oh, those were really sick kids anyway. That's actually not true, but was true for some of these. So definitely good to protect all kids. And again, all of us on the CDC panel talked about how we really believe in this for our own children and grandchildren. And vaccinating children is one of the best ways to protect themselves, keep them in school, help with their mental health, help with their development, growth, education, and then protect their teachers, protect their families, protect their grandparents. So it really helps them individually, but also is a major contribution to societal protection. So
just one comment on the kids. I think in some of the early studies, when we're looking at things like going back to school for kids, it was before the Delta variant. And I know, here in Massachusetts, it seems that kids are able to kind of hold on to and transmit the Delta variant more avidly than what we saw with the initial strains of COVID, and which means, obviously this is an adult heart transplant program with a bunch of adult individuals who have gotten transplanted. So obviously we care greatly about the kids and their health with this, but there's also this issue of the kids being a potential vector to bring this into homes and to spread it among adults that we really want to avoid having get COVID. So we're strongly advocating for kids as well as all the adults to get vaccinated.
Thanks for that, Greg. That's a really good point, and really good point about Delta and how Delta's really changed things. And, now we're talking about Delta, but there will be further mutants. And so good to protect ourselves now against what might be coming. So just a couple of comments on new medical treatments, because we had a lot of questions about that. So there is the new Merck drug, so molnupiravir, and this reduced hospitalization or death by about 50%. It looked at unvaccinated people who had not yet gone to the hospital. It's under FDA review right now. It has been approved in England for the treatment of mild to moderate COVID-19 in adults who have at least one risk factor for developing severe illness. And there's definitely a plan to license this in more than 100 low and middle income countries. Now, it has not yet been studied in transplant patients. We would anticipate that it would work in transplant patients, but I suspect that they're working on getting those studies underway. The other even newer drug is this Pfizer drug, Paxlovid. And this resulted in an 89% reduction in risk of hospitalization or death from any cause compared to placebo when treatment was started within 3 days of symptom onset. And here's the medication, the pink tablets, and it comes with the white tablet. The white tablet is a drug called ritonavir, which is used to help the effectiveness of the drug. And there are major drug interactions for transplant patients, but nothing that we can't work through. But just to say that if any of you were to end up getting this drug, we'd want to make sure that people were aware of the very strong drug interaction, because most of the time we end up cutting the tacrolimus or cyclosporin or sirolimus, depending on what you're on. And again, there's a plan for this to be made available in low and middle income countries, which is great. So how will these new treatments add to our current treatment protocol, or what we call our armamentarium? Both of these new treatments are pill form, which is great. It allows us to, hit hard, hit early, stop the virus in its tracks while still in the infectious phase. So best, to really start giving them as soon as there's a positive test result. The current treatments we have are remdesivir, which is an antivirus medicine, and dexamethasone, which is a steroid, much like the prednisone that many of you have taken or take. And these are intravenous, so it's really limited to people who are in the hospital. Gilead is working on a pill form of remdesivir, but they're not there yet. Monoclonal antibodies are also by injection only, either intravenous or subcutaneous or under the skin. There are other antivirals underway, so we're hoping to have a lot more treatments, but so far we only have 2 new ones that are out. And then it's not really clear what the FDA label will be. Initially, there won't be great drug supply. We are really hoping that there will be a possibility of giving this to transplant patients who develop COVID, but we will have to see about that. And Dr. Newton-Chay wanted us to really emphasize about what you should do when you test positive. And we would ask that you call us immediately so that we can advise you on symptom monitoring, isolation, and/or medication adjustments. And all transplant patients, vaccinated or not, could qualify for early monoclonal antibody treatment, which is when it works best. And we can help you with organizing that. But I do want to say before I go, we are really not out of the woods yet. You still need to mask, wash your hands, be careful about who you're socializing with, et cetera. Like that's still a really, really important part of all of this. And I think all of us on this call are still practicing, masking. My understanding is the plan for people, employees at Mass General will be to mask through the entire winter season. And so keep being careful with these other measures as well. And thanks for your attention, and happy to have more questions.
Great. Maybe I'll add a couple questions that came in that are somewhat related to these non-medical precautions, and then I'll loop back to the antibody stuff. So one question was, should a person pre-transplant be around unvaccinated people? And there's a second, I am interested in the current thinking about air travel for transplant patients. And I think these are, let's put them in the category of people trying to avoid acquiring COVID through behavioral means. Masking, washing hands are part of that. Megan, could you just comment on this? This must come up, it's holiday season. How are you discussing these issues with transplant patients?
So particularly with air travel, I'd say that we're always leaning on the side of caution, trying to keep people safe within their kind of own household is preferred, but also understanding that people have spent a year and a half basically at this point doing so. So trying to be realistic on that. So with air travel, we're advising that obviously they're wearing a mask, even double masking if they're able.
Can I ask, what kind of mask? Like the blue surgical ones, or the homemade cloth ones that have the dancing bears, or the KN95 or N95? Which ones?
We've talked about the blue surgical ones, the KN95s. I know have been more available to people. So we definitely prefer kind of those better barriers than the homemade cloth mask that can leave a lot of space between your cheeks or your chin. And as I advised previously, with the double masking, if you have a surgical mask then covered by a cloth mask, would be preferred if that's the means that you have. And then when you're traveling, trying to keep that mask on as much as possible, particularly when they go around to serve snacks and drinks on the plane, not taking your mask off at the same exact time that everyone else is doing so.
How's this, Megan? For the mask? I have my mask on.
And it's not ideal. We want your nose and mouth covered fully and pinching that wire bridge to form.
It's amazing how many people you see whose nose is sticking out.
Yes, exactly. It happens all the time. But yes, particularly when that snack cart comes around that you're not taking your mask off with everyone else. That's a big thing that I think a lot of people said, I didn't even think about that. And that's one thing, making sure that you're washing your hands frequently, avoiding touching your face as much as possible when you're traveling, and bringing plenty of new masks as well while you travel. Also ensuring that if you are traveling outside of your state or beyond your home, that you're bringing enough medications with you should unfortunately you get exposed to COVID and you get stuck somewhere. We want to make sure that you have enough medication supply to hold you over, and obviously still calling us no matter where you are, so that we can advise on how to manage you wherever you are.
Great, that's super. And it kind of dovetails. I mean, I think we're all feeling the toxicity of getting this deep into a pandemic and still not being back to normal. I remember those first few months, people thinking, oh, it's going to be 6 months and we'll be better. We have had several comments that have come in through Instagram or through the chat about how to handle the physical and emotional isolation of COVID due to being a transplant patient, or maybe by analogy, we could say being a caregiver or family member of a transplant patient, where we recognize, the health and well-being of our transplant patients is really critically dependent on their families. How's that going? Like, what's your sense of how people are dealing with the physical and emotional isolation?
It's been hard. Certainly, I think across the board, from patients to caregivers to providers, because it hasn't stopped. We've all been waiting for that kind of that pause, but it hasn't quite come yet. And I think the summer was a little bit nice, where cases were down and people could be outside. But now that we're seeing the rising cases again, people have expressed a lot of concerns. We've certainly had people reach out to us saying that they're feeling the emotional toll of the isolation on them. We've been able to connect them with counseling if they've needed to do so. Many of you are aware of some different transplant-specific resources like Heart Brothers and different kind of Facebook groups or online groups that you can kind of reach out to different people. But I know that they've really been leaning on their families and others kind of in this position. But unfortunately, we're still erring on the side of caution that we want you to protect yourself and protect your families as much as you can by being conscientious about who you're with, where you're going, and those types of things.
Great. And maybe while we're on that subject, could you just comment on kind of general holiday advice? Like, I saw that Dr. Fauci had been widely quoted as saying, if everybody in the house is vaccinated, go for it this Thanksgiving, or so that's how it gets paraphrased. How are you advising transplant patients and their families about the holiday season?
Yeah, that's a really heavy question right now. I think last year, where things were, we didn't have the vaccine last year. And so it's really easy to say, all right, everyone do Zoom Thanksgiving, Zoom holidays, and that's what you get. This year, with the vaccine in play, I think that's made that conversation a lot harder. I can say personally with my family, we've had to have some of these really hard conversations that we never expected to have. But we've always said that you can blame us. We can be the bad guys to say that, we're advising that you keep your circle very small, hopefully with vaccinated people, potentially testing ahead of time based on your resources. And again, those aren't foolproof, but trying to protect yourself and your family members.
That's a really good point. It's something that I don't think I've really seen much guidance in either CDC or other public health guidance about the role of testing, like home testing and rapid tests and those things. I mean, I know when people get sick, everybody knows they need to get tested. Do you know, Camille, are there any? I think there has not been head-to-head comparison of different home testing kits. I have seen some data Obviously there are kits like Binax Now has been pretty commonly available. I haven't seen it so much lately on the shelves. Quick View is another. I know there was a recall of some of the Illum home testing kits because of some unreliability, but can you just comment in general on, like, if someone wanted to test everybody the morning before Thanksgiving or something, what do you think their options are?
Yeah, that's a great question, Chris. So, the rapid tests are not all that sensitive or accurate, especially if someone is not symptomatic. So if somebody wakes up and they have a fever and a runny nose and all of that, I think that they tend to be quite good at diagnosing COVID in that situation. But either people who have no symptoms, we call them asymptomatic, or just for routine screening, I've seen that the sensitivity of some of those tests can be as low as 50%, which means it's like a coin toss. And the other thing is that they can be pretty expensive. So my friend wanted to do this for Thanksgiving, but she spent over $100 on the tests. So I think people should be aware that they're expensive. They're sure easy to do. That we call it, the technology is what I call a urine pregnancy test. So it's basically like you kind of read the instructions. If you can dye your own hair or do a urine pregnancy test, you can do this kind of testing at home. Anyway, so it's easy to do, but it's just not that accurate. And I am really worried. I had a friend who had an outbreak at her house because the test was falsely negative. And then her mom got infected, her 84-year-old mom got infected from one of the grandchildren, because the testing is not perfect. So I'm hesitant to recommend that. If people are getting together anyway, and if you've decided like that's just what we're doing, and some people have just made a decision for various reasons that they're going to get together, then it's reasonable to include. But I wouldn't necessarily hang my hat on it, if that makes sense.
So it sounds like if you get a positive test, if let's say you are doing testing of family members, and we're not talking about transplant patients here. We're talking about the people who are trying to protect transplant patients or protect the whole household, let's say grandparents. Positive test means you sit out the holiday celebration and you isolate. Negative test, it doesn't mean you're free and clear. So it is still possible you could either be incubating and not yet positive, or it could have missed it where maybe a PCR test might have picked something up. Because I will say that in my family, we have purchased some of these Binax Now tests, and I can't speak to the test characteristics. I mean, I know what is on the product insert, but we've used those before. We let my teenage boys see their grandparents on the day of their going. So rather than have to wait 24 hours for a PCR to come back. And while we recognize there's a chance that we'll miss something, we're trying to add a little extra layer. But you're right, it's $13 a test for that testing kit. And I think for us, the advantage has been that it's easy to use and we can do it at home. But we recognize that. Lana, Greg, do you guys have comments on this testing or holiday precautions?
Yeah, just one thing to add on the testing kits is that the likelihood of them being positive, it correlates with the amount of virus that the person is carrying. And so they have better performance characteristics in someone that's highly symptomatic, but the very informed patients that we have on this call, certainly know that if their relative is having terrible symptoms that morning, that it's not going to be a good idea to connect. The concern I have is that you could have virus being harbored at great enough quantities to get one of our transplant recipients sick with COVID and not trigger a positive Binax Now or one of the other rapids. So it just, unfortunately, I'd hate to have it be a false sense of security for
Greg, if I could amplify, I think we're talking about asymptomatic people. I think anybody who has symptoms, we think they should get screened for COVID because anything like a cold symptom after vaccination or in young people could be a mild case of COVID that's easily spreadable. But so we're talking here about people without symptoms. And I think sounds like Greg and Camille, you're both giving a strong note of caution to put too much emphasis on the rapid test. Lana, did you have a comment?
Yeah, I'm not a fan of the rapid tests. I think it gives people a false sense of security when they're asymptomatic. So, and also it is costly. And as far as the get-togethers, I know we're all tired of being home and we're not with our loved ones, but we just have to be really safe. And when we are getting together, I think people should still be wearing their masks so they don't know the status of what other people are doing, and washing their hands every 20 seconds or 20 minutes that was in the last slide that Camille showed. I think we just have to still be really cautious. It's out there.
But definitely, I totally agree with caution. I actually have this whole spiel that some of the patients would have heard, but get a really good puffy coat, just like Dr. Newton-Che I think he wore that for this call. So a really good puffy coat, a good hat, matching gloves, like really rock the outdoor fashion, and then mask up. And it's actually nice and cozy behind a mask in New England. It's another way to stay warm. And then go out and see your friends, go for a walk, you can be outdoors. You can, you can do takeout food. You can sit at a park bench. There are lots of ways of being creative and still socializing, because we all do really miss each other. I know in the hospital, we miss seeing each other in person the way we used to do. So there are a lot of ways that you can work around it. I'm recommending things like outdoor cocktail parties for the holidays or Thanksgiving, or if you want to see friends. But like outdoors, make yourself comfortable, dress appropriately. It is a good, what Lana said, it's still a good idea to wear a mask, I think, even unless you're really far apart outdoors. But if you want to be super safe, that's the safest of all.
Great. Lots of good advice, and you can hear a diversity of opinions. It's good to know. This is not settled science yet. It's a new pandemic, new virus. 2 years ago, we'd never seen it. Just a reminder, if folks have questions, raising your hand won't lead to the question being answered, because we don't have a mechanism for patients, for privacy reasons, to directly ask their questions. But if you post a question to the Q&A, I'll make sure it's addressed. So it looks like there've been a few people who've been raising their hand. There's a question that came in. Can I get the Regeneron shot to be sure to be protected? And this came in during your talk, Camille. And I think there are a bunch of related questions, and I'm not sure we've touched that much on what are the benefits of monoclonal antibody infusions, and who gets them, and what's the importance of timing there. And then I guess the related question would be, there have been some reports of prophylactic or preventive infusions of monoclonal antibodies for people in high-risk settings, like a work setting, and what kind of protection patients might get. And I was inferring that that was the question being posed by the questioner, but maybe you could start by, what is the role of monoclonal antibody therapy, and what does it do for a patient?
So right now, monoclonal antibodies are approved for what we say emergency use authorization, which is the same phrasing used for the vaccines, but basically have been approved by the FDA for people, high-risk people who've been exposed, like maybe, your spouse or family member develops COVID and you're in the household and you're a transplant recipient. So that would be a strong reason to get monoclonal antibody, even if you've had the vaccine. And then if you test positive, even with vaccine on board, good idea to go ahead and get monoclonal antibody. And many healthy people, not transplant patients, but healthy people are getting monoclonal antibody, whether or not they've been vaccinated, as soon as they test positive. And then we can't give the monoclonal antibody, at least not easily, once you're hospitalized. So it is something that's really good to do ASAP, and that's when it works best. And I always think, Chris, just making it really simple, I always think about the antibody like literally kind of eating up the virus. So if you have virus and the virus is starting to spread, and then you give the antibodies are almost like, for those of you that are old enough, they're old enough or young enough, but it's almost like Pac-Man. Remember Pac-Man? And eating up all the virus. So that's kind of what monoclonal antibodies are. They do last in the body at least 3 months. And so there has been this idea that maybe we could give it for prevention. But right now, we don't have that FDA approval. So right now, we can't give it for prevention yet, but there will be studies. And so it might be able to be done in a research setting. And then hopefully, eventually, we will show that it is really protective. And for people that did not have a strong response after vaccination, we may be able to give these monoclonal antibodies that seem to be very safe, very safe and effective, and basically sit in your body for 3 months, almost like little, I should say, not Pac-Men, but Pac people. And they eat up all the virus as soon as it comes. So
nice. Even PC hits Pac-Man. So it's safe to say, Camille, that it's not like you wait till you get sick and then you're sick enough to need monoclonal antibodies. You're saying from the time that you first develop symptoms and test positive, as soon as you learn that, even if you don't have symptoms or you're minimally symptomatic, like stuffy nose, that's the time to get the antibody. Megan, can you talk about what you've been doing for patients where we learn about their test positivity, transplant patients?
Absolutely. So yes, as that first stuffy nose or that first onset, as soon as you get that test result back, we want to get that phone call. So whether it's a daytime, calling us at the office, or off hours with our on-call number, let someone know. It's very easy through the MGB system for us to put in a referral for monoclonal antibody. And just from our experience, most patients are getting a phone call within 48 hours from the infusion center, and they're usually getting infused within 48 to 72 hours. I know that they've expanded their sites, and there's some other sites in Massachusetts. If you're out of Massachusetts, we've been able to connect with PCPs in the area to tell us some local sites you can go to. But it's usually happening very quickly. So it's been great, but getting us that first phone call is really critical to the timeline of all this.
And even to back up one step before that, it's the getting tested. You know, it can manifest in various different ways. You don't have to have every single symptom, including loss of taste and smell. You know, go ahead and get tested, because there are things that we do differently. We do modify the doses of your immunosuppression. There's the monoclonal antibodies, as Dr. Cotton alluded to. We have more treatments that are in the pipeline. So it's, you know, the knowledge of having it helps to navigate the illness. So go ahead and get tested if you're having symptoms.
Great. And it looks like a question came in, and it's pretty much a question that was asked by another, and it's for someone who's gotten 3 doses and has no detectable antibody or T-cell responses. Do you have recommendation about coming treatments like monoclonal antibody as a prophylactic? And it sounds like that's still in the research setting. It's not been tested. And number 2, we don't know how to incorporate T-cell response or antibody level in deciding whether a patient's at risk for severe disease or not. So we're currently not recommending using that, but it sounds like it's too early for prime time. There's a question that came in: what's the best way to get tested? And I guess we could interpret that to be 2 different ways. And maybe this will be our last question. What are the ways that our patients are getting tested, Megan? And I guess you know, we're not just in Massachusetts. There's New Hampshire and Rhode Island, Vermont, Maine. I mean, I've fielded calls from patients in all of these areas. What guidance do we give? Let's say that they're outside because I think a lot of people assume the hospital is going to be the place they're going to come to get tested. We're going to test them. But it seems like it's a diversity of testing places, whether it's at the town or the state level, and it differs by state. Is that fair?
Yes, absolutely. And I will say that our admin staff are experts at scheduling COVID tests at this point and can help you across states to schedule one if you're struggling. You know, honestly, just a good old Google search for a COVID test works pretty efficiently in most cases. So wherever you can find one the fastest is really the best thing.
Great.
And if you can choose from between the different ones, you know, we've talked a lot about the rapid tests and things like that for home-based testing, but try to get the PCR tests. They're not the same as they were if you got tested at the beginning of the pandemic in terms of going all the way up the nose.
Great. And there's Camille commented that her family's used Project Beacon in Massachusetts to identify getting free and fast test results. There was another question that came in through the chat about how long a family member has to isolate after overseas travel before rejoining a transplant patient at home. I guess we would call that not necessarily isolation. We'll presume they're not known to be COVID exposed or COVID infected, but what kind of time interval do you think is reasonable after someone's been traveling and, let's say, mixing with other households, especially including overseas, which was the question. How long do you think is reasonable, Camille, and is testing involved?
I would do 7 days with a PCR test, and if negative, then I think that's fine.
Do the test at 7 days?
At 7 days, so then it won't be until day 8 or day 9 that they rejoin. But that would be like the absolute safest, because that's going to be fine.
Excellent. Well, we look forward to posting this on YouTube, and we'll send around the link, and we'll try to put it out on social media. But very grateful for the time from Greg, Megan, Lana, Camille, from Kathleen, Diane, and Stacy behind the scenes, helping to put this together. But we really wanted to get the information out for all of our patients and their families. We really hope you all have a very happy, healthy, and safe Thanksgiving and holiday season. And we look forward to talking to you in the new year as well. Okay, thanks.
Happy holidays, everyone.
Yeah, thanks for coming.